Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy.
What if the way that we've been treating narcolepsy is about to change completely? New therapies are advancing in the pipeline, guidelines are being rewritten, and patients, well, they're starting to expect more than just manageable symptoms. They want their lives back. This is Unscripted, the AMCP podcast. I'm Steve Kheloussi, Principal Consultant at Kheloussi Consulting and a managed care pharmacist by background. This episode is supported by an independent medical education grant from Takeda Pharmaceuticals USA, Inc. Please make sure to check out the show notes for additional information. Joining me today is Amy Lugo, PharmD, and the founder and CEO of LoneStar Health Solutions with expertise in managed care pharmacy consulting. Welcome, Amy.
Thanks, Steve. Thanks for having me.
Of course, and I think congratulations are in order here because you have recently been recognized as a fellow of AMCP as well, so congratulations on that.
I was, yes. Thank you so much. It's such an honor.
Well, let's get into it. Today, we're going to be talking about what's coming in narcolepsy type 1 treatment, how it's reshaping what patients are asking for, and what that means for coverage, access, and outcomes in managed care. So, Amy, let's get started with the basics. What is narcolepsy?
Sure thing, Steve. So narcolepsy is a chronic neurologic disorder. Ultimately, there's a loss of orexin-producing neurons in the lateral hypothalamus. And what that translates into for patients is a very difficult, troublesome problems with their sleep-wake cycle. Ultimately, the orexins are not doing their job. They're just not there. And so your sleep-wake cycle is really messed up, where patients can quickly fall into REM sleep and they will have plenty of time and opportunity in the bed, but they wake up exhausted because they're not getting good sleep-wake cycles.
Oh, wow. And I mentioned earlier, we're going to be focusing today on type 1. How does type 1 differ from type 2?
Sure. Type 1 ultimately is with cataplexy. And so cataplexy is this sudden loss of muscle tone. It could be due to sudden laughter or an emotional situation. So you can imagine that patients are really concerned about how this would make them look in front of others at work or at school, anywhere really. And so coinciding with cataplexy is what differentiates it from type 2.
Wow. Okay, great. And how common is type 1?
Ultimately, type 1, the incidence is about 1.2 per 100,000 persons each year.
Okay, so pretty rare. And what kind of treatments do we have for narcolepsy right now?
Right now, today, we have 5 different agents that are available. The old school are modafinil, the stimulants, and they have cost-effective, cheap, generic versions at this point. We also have sodium oxybate. There are 3 different versions of that. Now, that's been around since 2002, so there's an authorized generic of that original version. And then we have the long-acting version that's called Lumryz, and then the low-sodium version is called Xywav. Additionally, in the last 6 or 7 years, we have 2 newer products. I say newer just because they're not 20-something years old or 30 years old. Solriamfetol and pitolisant.
Interesting. And what do the guidelines say? Are these all first-line agents? You just kind of pick whichever based on patient-specific factors, or are there certain patients that should be using certain medications?
Yeah, the American Academy of Sleep Medicine guidelines were most updated. They're kind of old, actually, but they were last updated in 2021. They do recommend probably going to have a wakefulness promoting agent during the day, a stimulant like modafinil or armodafinil. There's strong recommendations for those. There's also strong recommendations from the guidelines for sodium oxybates and solriamfetol. Probably going to have the sodium oxybates at night and one of the wakefulness promoting agents during the day.
Interesting. And you pointed out something that I'd heard in the past about the name of these medications, sodium oxybate, for instance. We can't just ignore the sodium component of it. What are some of the benefits or the downsides with the available treatment options as they stand today?
Yeah, so sodium oxybate, unfortunately, has a significant sodium load that comes with it. So that original version, as well as the once nightly version, have a significant amount of sodium. They are giving you 2,300 milligrams per day. In the American Heart Association, ultimately, the goal is less than 1,500 milligrams per day of sodium if you have hypertension. And so that is a concern. And they did come out with the low sodium version that's called Xywav that has 92% less sodium and a total of 131 milligrams at max dose. So there is that availability.
Interesting. So if I'm understanding that correctly, the older versions, not the low sodium version, that will put you well over your daily allotted amount of sodium just before you consider dietary intake as well.
Yep, that's exactly right.
Oh my goodness. Okay. Well, it sounds like there's some movement in this space in terms of the low sodium product, but maybe still a need for patients. From what I understand, there's emerging treatments coming out in this area as well. Can you tell us about the orexin 2 receptor agonists?
In healthy individuals, orexin signaling normally stabilizes wakefulness and prevents inappropriate transitions and sleep. And because in NT1 patients, we have this loss of orexin, it allows rapid transitions into sleep and REM cycles that are no good. Ovaparexin is this new agent coming from Takeda, and it hopefully might be approved later in the year, this year or early next year, unsure exactly. But it's pretty exciting because it will ultimately treat the underlying problem with narcolepsy type 1.
That's really interesting. And as we were talking about orexin, it dawned on me that we also have several dual orexin receptor antagonists, or the DORAs, right, used for insomnia. In that case, they promote sleep. So in this case, we're looking to achieve basically the opposite effect while working within the same physiological pathway. Is that right?
Yep, that's exactly right. So the DORAs, they've been around for a while. Suvorexant came out in 2014. And then limborexant and daridorexant. So those DORAs are dual orexin receptor antagonist. Ultimately, those are for insomnia, and they're contraindicated in narcolepsy because what we're trying to achieve is the opposite, just like you said, Steve. And so we have orexin 2 receptor agonist here with ovaparexin.
That's really interesting. And you point out that they were approved not all that long ago. And I think that's a really interesting point because this pathway is relatively new in terms of being a treatment target for insomnia, and now very new for the narcolepsy side of things. And so in terms of how this compares to the existing drugs, this one sounds like the medications targeting orexin are going to be targeting the underlying pathophysiology, whereas the existing agents, what are they doing exactly?
Yeah, they work on dopamine ultimately and dopamine signaling. And so that's how the older agents worked. For example, pitolisant worked in the histamine pathway. The others worked in serotonin and norepinephrine, and none of them were really working on the missing orexin signaling there. So that's what's so exciting here is because it's the underlying problem. And ovaparexin, for example, being an orexin agonist, would work in that pathway to promote wakefulness and kind of fix that sleep-wake cycle that's messed up.
Interesting. And are there any other orexin 2 receptor agonists in the pipeline as well?
Yeah, there are. They are a little bit farther out in the pipeline, but there's an alixorexton. That one is moving into phase 3 trials in the Vibrance and Brilliance studies. So that one was given breakthrough designation early on. But again, it's a little bit farther out. They have just started phase 3 trials. And then there's another product called ORX 750. That one is in phase 2 studies. So our best bet for something soon is the ovaparexin.
Yeah, that's really exciting. And what's your sort of final takeaway for this class of medications and for ovaparexin specifically? And what is this going to mean for clinical practice?
I think it's going to change clinical practice a lot. We've always just sort of treated the symptoms before, hoping that we can get people awake with those stimulants, the older agents, and then hoping we can hopefully get them to sleep with the sodium oxybate. But again, it doesn't treat the underlying problem. And so if orexin loss is the main issue and orexin agonists are going to help that. So I think it is really going to change the treatment paradigm.
That's so interesting. And instead of requiring multiple medications potentially, is it anticipated that based on the clinical studies, were patients treated with multiple medications that are existing on the market in addition to the orexin receptor agonist, or is this monotherapy?
They were treated previously with other agents. These folks were in the phase 2 study. So we don't know exactly yet whether these current products will continue on with an ovaparexin patient, but these folks were treated previously with the other agents.
Okay. Yeah. And that makes sense. And thinking about this from the managed care perspective, whenever something practice changing like this comes out, it's always met with a little bit of hesitation from the managed care side because it's new and we don't have anything to compare it to and can't necessarily compare it to the older agents. So I'm sure there's going to be a little bit of hesitation when covering this as a first line therapy. Site guidelines tend to take time to update. That's probably the disease area that is slowest to update. You said 2021, so maybe in the next few years we'll get a guideline update.
Yeah, that's right. I presented with Dr. Luis Ortiz a couple weeks ago in Nashville on this topic, and he's a sleep medicine specialist, specifically in peds. And interestingly, he has narcolepsy type 1 also, and he shared his patient journey. But he was mentioning that the guidelines are expected to be updated. Again, we don't know for sure, but he believes that they'll be updated soon.
I would imagine also that there's an emphasis being placed on updating those guidelines sooner than later once this agent hits the market to support uptake from providers and from managed care organizations alike. You mentioned your presentation at AMCP. It was an excellent presentation. I want to pull one aspect out of there that we can maybe talk a little bit more about. And that is that the co-presenter that you just mentioned is also a patient with narcolepsy, but then there was a second patient on the panel with you as well. And so I would love to get your take on what did you get from that conversation? What did you hear about what it's like for patients with narcolepsy type 1 to live with this disease?
Well, Steve, I got to be honest, I was the third presenter in the panel that day. And typically you're just sitting there waiting for your time to stand up and do your part. I was absolutely blown away by the two providers and patients that shared before me. Shelby Cole is a nurse and she has narcolepsy, and Dr. Ortiz, a physician with narcolepsy. And so while they shared information about diagnosis and the patient's journey, I stood up as the third panelist and was like, oh my goodness, who am I to be sharing anything about narcolepsy? Just how they overcame what they had to go through. Dr. Ortiz was in medical school, trying to stay awake, trying to study, trying to be in class on time and so forth. Shelby was a nurse and again, working or being late to work. And people see these folks as being lazy, not having work ethic, that sort of thing. Shelby shared that her diagnosis finally gave her validation. Typically, the diagnostic delay is significant here. Most folks, it takes 8 to 10 years to get diagnosed, which is crazy because, again, it's often missed or seen as inattention or ADHD or OSA, right? Obstructive sleep apnea, where you're just not getting good rest. So that's typically what is seen. Patients are seen as just being lazy. Shelby was sharing that her journey gave her validation, like, wow, I really do have a problem. It's not just me being lazy or being tired. She said that her diagnosis was life-changing for her, difference of day and night. It allowed her to be functional, safe, and fully present in her life and with her family. I was really blown away by the stories that Dr. Ortiz and Shelby shared, just the impact it had on their lives.
Yeah, that's so powerful to hear that firsthand from individuals who are going through this. And I think that really is an aspect that we sometimes miss sitting behind the computer at the managed care side, not interacting with those patients face to face. We're looking at the clinical studies. We want to help make as evidence-based a decision as possible. But really, when you personify the disease and you hear somebody's story and their struggle, and that really changes the way that you look at these conditions. And so how would you say that the emerging therapies are addressing the patient needs in a way that the current therapies are not?
You said it exactly. Like in managed care, we sit behind a desk, right? We don't see patients regularly. I would really challenge every managed care pharmacist to think about this disease state differently. We're often like, oh, the cost of sodium oxybate has been the bane of our existence. And we just really need to open up your eyes to what's going on with these folks. And again, their diagnostic delay. So the excitement about oveporexton and drugs that actually are treating the underlying disorder, we have to be thoughtful about designing a benefit that allows for patients to get to this newer therapy if it ultimately fixes the underlying problem. But then also being thoughtful about medical benefits, pharmacy benefit, and not having sort of a siloed care, if you will. We also need to be thoughtful about not putting up additional barriers for limited distribution, specialty pharmacy situation. We know that we're going to have all of these utilization management tools in the toolbox, but just be thoughtful of the patient and having to navigate all of that.
Yeah, that's a great point. It's not just about getting the drug on the formulary. There's a lot of other considerations that we have to think about as well. And so one of the major considerations is in terms of value. Now, we don't have pricing information necessarily for oveporexton just yet, based on the fact that it's not on the market or anything like that. But is there any data on the value of oveporexton?
Yeah, so ICER, the Institute for Clinical and Economic Review, ICER did a review back, I guess early this year, and they looked at the effectiveness and value of oveporexton for narcolepsy. They had a lifetime time horizon. They had different health states, including initial treatment and subsequent treatment and death. So the perspective was from the health system. They looked at oveporexton 1 milligrams twice a day and 2 milligrams twice a day. The outcomes particularly that they looked at were daytime symptoms like excessive daytime sleepiness and cataplexy, REM-related symptoms, work and school performance. So they kind of looked at all the literature that was out there. Now, one of the things that they particularly said was for their clinical summary is that oveporexton resulted in statistically significant and clinically meaningful differences in the mean wakefulness test, as well as the ESS score, which is one of our primary endpoints in these kinds of studies. The ICER review I was referencing was in draft form, so make sure you keep an eye out for the final report.
Interesting. And for my benefit, as well as the audience's, ESS, is that an acronym that you can define for us?
Sure thing. Yeah, ESS is the Epworth Sleepiness Scale, and it's an 8-item patient-reported questionnaire. So a PRO here, patient-reported outcome that looks at the likeliness of falling asleep during usual daily life activities. So it ranges from 0 to 24, again, an 8-item score. Each item is given 3 points, so a total of 0 to 24, where 0 to 10 is normal and 16 to 24, for example, would indicate severe sleepiness.
Interesting. And it'll be interesting also to see how managed care organizations react, because generally speaking, there is some hesitation to use patient-reported outcomes in formulary decision-making because of perceived risk of bias.
Yeah, but I think it is the primary endpoint in the majority of these narcolepsy trials. It's what we have. And the ICER review did show ultimately that oveporexton had better results compared to all the other treatments. They did say that the cost effectiveness of oveporexton compared with no drug or other active treatments will depend, of course, on its actual price when it launches.
Of course, and I'm sure that ICER is going to be taking a look at this once that information is known, hopefully provide an update on the cost effectiveness of oveporexton when the time comes. Amy, so this is the Unscripted podcast, and so we like to ask at the end, what is your one unscripted truth about narcolepsy? What's the most important take-home message about something the audience may not know already?
Yeah, for me, it's that patient journey that really was impactful. And it makes me think about designing PA criteria that are not a hindrance to the patient, really keeping the patient in mind. And something we didn't hit on, Steve, was also the additional comorbidities that come along with narcolepsy. Again, keeping that patient in mind. There are significant comorbidities that these patients are managing, and being thoughtful again about the whole journey that the patient is trying to navigate.
Fantastic. Yeah, I think you raise a great point right at the end there, that we can't think about narcolepsy in a vacuum. And as we think about the treatment of narcolepsy, we need to understand also how that's going to potentially impact a whole host of other conditions that typically come with narcolepsy. So Amy, thank you so much for your time today and all of the valuable information. It really sounds like the future is bright for this space.
It does. Thank you so much, Steve. I appreciate it.
And thank you to our audience for listening to this episode of Unscripted, the AMCP podcast.